A 45-year-old patient presented with progressive confusion developing over 1 week. I'm showing you T2-weighted axial brain MRI scans. Describe the findings.
Let's see. Yes. The T2-weighted MR images demonstrate diffuse, asymmetric hyperintensity and swelling affecting the right temporal lobe. This signal abnormality involves both the cortical gray matter and subcortical white matter, extending completely to the cortical surface. There is significant local mass effect with effacement of the surrounding cerebral sulci. Similar hyperintense signal changes are visible extending along the right cingulate gyrus and also involving the contralateral left temporal lobe to a lesser degree. The deep gray matter structures, including the basal ganglia, are spared, which is typical for this condition.
I am showing you axial brain CT scans of 2 different comparison cases. What do they demonstrate, and what is the differential?
The first comparison CT scan demonstrates a classic right middle cerebral artery territory infarction. This is characterized by low attenuation changes and swelling in the right temporal lobe, accompanied by a hyperdense MCA sign indicating acute thrombus. The second comparison CT scan demonstrates a posterior cerebral artery territory infarction, showing low attenuation in the posteromedial temporal lobe. The primary differential diagnosis for acute temporal lobe swelling includes herpes simplex virus encephalitis, a middle cerebral artery vascular territory stroke, a glioma, and status epilepticus.
Explain the key clinical features, pathology, and classic anatomical distribution of herpes simplex virus encephalitis.
Herpes simplex virus type 1 is the most common cause of sporadic fatal encephalitis, resulting from either primary infection or reactivation in the trigeminal ganglion. Clinically, patients present with acute fever, headaches, altered mental status, and focal seizures progressing rapidly to coma. Anatomically, it is a necrotizing hemorrhagic encephalitis that typically targets limbic structures, specifically the medial temporal lobes, inferior frontal lobes, insula, and cingulate gyri. Bilateral but asymmetric temporal lobe involvement is highly characteristic and virtually pathognomonic of this infection.
How do you radiologically differentiate herpes simplex encephalitis from a middle cerebral artery infarction?
A middle cerebral artery infarct is restricted to a specific vascular territory and typically spares the posteromedial temporal lobe, which is supplied by the posterior cerebral artery. In contrast, herpes simplex encephalitis preferentially involves the medial temporal lobe, sparing the basal ganglia, and does not respect vascular boundaries. Also, cytotoxic edema in stroke causes rapid gyral swelling and restricted diffusion that is vascular bound, whereas herpes spreads along limbic pathways. CT changes in early herpes encephalitis are subtle and may be normal, whereas MRI showing bilateral temporal flare or DWI hyperintensity is highly sensitive.
Discuss the management, prognosis, and how you would manage this patient as a radiologist.
Herpes simplex encephalitis has a high mortality rate of up to 65% if untreated, making urgent management critical. Intravenous acyclovir therapy must be initiated immediately upon clinical suspicion, without waiting for lumbar puncture or imaging confirmation. As a radiologist, if I suspect this on a brain CT or MRI, I would immediately call the referring clinician to report the critical findings. I would recommend an urgent lumbar puncture for CSF PCR analysis and prompt initiation of empiric antiviral therapy.